Hello, my name is Anne-Marie Valenti, and I am the co-director of the Pregnancy and Cardiovascular Disease Program at the Brigham and Women's Hospital. I do not have any disclosures. There are 4 objectives for today's presentation. The first is to recognize that women with heart disease experience maternal cardiac events during pregnancy and the postpartum period. Secondly, we would like to identify the risk factors for adverse maternal cardiovascular outcomes. Then, we will discuss how to manage women with acute cardiac conditions during pregnancy. And finally, we will discuss the management of pregnancy in women with certain cardiac conditions. Let's start with a question. A 28-year-old asymptomatic woman is referred for evaluation of a murmur noted during the early second trimester of pregnancy. She has no history of cardiac disease. Physical examination confirms a pulse of 95 beats per minute, blood pressure of 110/85, a 2/6 systolic ejection murmur at the left sternal border, and an apical S3. What is the most likely cause of this murmur? Choices are A, moderate aortic stenosis, B, tricuspid regurgitation, C, severe pulmonary stenosis, D, physiologic murmur, or E, bicuspid aortic valve with severe aortic stenosis. The answer is D, physiologic murmur of pregnancy. And this question really just speaks to the importance of understanding some of the physical exam finding changes that occur with pregnancy. The other answers are incorrect, basically because you would need more information for most of them. For the cases of aortic stenosis, you would want to listen to the S2 to see how that's affected. Tricuspid regurgitation would be more of a holosystolic murmur, and severe pulmonary stenosis would also have other findings, potentially a click, as well as a much more harsh systolic ejection murmur. So let's start by thinking about the hemodynamics in pregnancy by looking at this graphic. Here we're going to see the duration of pregnancy in weeks on the x-axis and the percent change in hemodynamic values on the y-axis during pregnancy. If we start with plasma volume, seen here in this red line, you can see that there's a dramatic increase in plasma volume that women experience during pregnancy. In fact, it goes higher than 40% of pre-pregnancy values. This peaks at the end of the second trimester and beginning of third trimester. Now compare that to the changes in stroke volume, which also increase, but happen much earlier in pregnancy. Stroke volume increases over 25%, and that really occurs early on and then peaks right around the middle of the second trimester. It remains elevated until the postpartum period. Heart rate also goes up. Not quite as much, usually about a 10 to 15% heart rate change throughout pregnancy, and you can see it mirrors the timing of the stroke volume changes. Women sometimes experience feeling this change in heart rate as a perceived sense of tachycardia. Cardiac output surges, again early in the pregnancy, really starting in the beginning of the second trimester. Women's cardiac output can increase up to 50% of pre-pregnancy values, and there's dramatic changes in that cardiac output that occur in the early postpartum period. Now, the one factor to remember that decreases during pregnancy is the systemic vascular resistance. Think of the placenta as a wonderful afterload reducer. And you can see throughout pregnancy, the systemic vascular resistance actually goes down upwards of 30 to 40% of pre-pregnancy values. Those changes are going to affect how women with underlying heart disease respond to pregnancy. Further changes occur during labor and delivery. We know that during labor, women experience dramatic changes in their cardiac output. That's shown here in this graphic with the stages of labor on the x-axis and the change in cardiac output liters per minute on the y-axis. You can see these blue bars are displaying the cardiac output during contractions, and in the later stages of labor, women's cardiac output can exceed 10 liters per minute. Women also experience increase in their heart rate, their blood pressure, and venous return. And during that postpartum period, things are accentuated due to autotransfusion of blood from the placenta, further increasing preload and cardiac output. And it's here suddenly that the systemic vascular resistance starts to rise. And that is why early in the postpartum period, for some women with cardiac disease, they run into trouble. So when we think about the physical examination in pregnancy, many women appear a bit almost hyperthyroid. They have brisk cardiac upstrokes. There can be mild elevation in the JVP, which is normal. They often have a systolic ejection murmur indicative of the increased flow. Mammary soufflot can also be heard, as well as an S3 gallop. Here, in pregnancy, an S3 gallop can actually be a normal finding. Many women experience mild pedal edema, and varicose veins are increasingly common. Now compare those to the abnormal findings listed here in blue. Things that are not normal in a pregnant woman would be a new holosystolic murmur or a diastolic murmur, an S4, or fixed splitting of the S2 heart sound. Additionally, rales in the lungs are not a normal finding for women in pregnancy. Thinking about auscultation, it's important to note that the murmurs change during pregnancy due to some of those hemodynamic changes. That is, murmurs from stenotic lesions become louder due to increases in preload and cardiac output, whereas murmurs from regurgitant lesions often get softer due to the decreased systemic vascular resistance. A murmur from a ventricular septal defect also gets softer for that same reason, the lower SVR that women experience during pregnancy. And here's an example of a typical echocardiogram of a woman in the third trimester, just demonstrating the increased cardiac output. This is an off-angle short-axis view. This can often be mistaken for an ASD. As you see here with color, this accentuation of flow. This is just normal flow that's coming from the IVC back to the right atrium. But as we remember from that hemodynamic curve, there's great increases in plasma volume and cardiac output. So it's important to mention that if women undergo echo during pregnancy, you will see some changes. All 4 chambers dilate during pregnancy, up to 10% of their pre-pregnancy values. There's varying data on the ejection fraction and contractile function of women during pregnancy, but overall the LVEF should remain stable. The left ventricular mass increases 5 to 10%, and that leads to a process of eccentric hypertrophy, which creates cardiac globularity. And this is one reason why looking at the ejection fraction can be difficult with standard methods, as the shape of the heart has changed. Other echocardiographic findings include valve annulus diameters increased, and patients get increased regurgitation. The pulmonary artery pressure should remain normal, and in fact, the pulmonary vascular resistance may drop a little bit due to vascular recruitment. Notably, pericardial effusions occur in up to 25% of women during pregnancy. Most of these are small and hemodynamically insignificant. Another fact about pregnancy is that it is a hypercoagulable state, and we know that many hematologic changes occur. I've listed some of them here. These predispose women to thrombotic events and include increase in clotting factors, increase in platelet adhesion molecules, increases in certain placental molecules that inhibit some of the normal hemostasis, as well as decreased fibrinolysis and decreased protein S activity. Now, why is risk stratification important in women? Well, this is data from the Center for Disease Control, which estimates that up to 2% of pregnancies are complicated by maternal cardiovascular disease, and that congenital heart disease comprises about 50% of the maternal heart disease in pregnancy. Additionally, rates of hypertensive syndrome, such as preeclampsia, are increasing in the United States, and deaths attributable to maternal cardiac conditions have increased in the past decade. This is not a problem that's isolated to the United States. Here is data from the United Kingdom in their report looking at maternal deaths, and you can see that cardiac disease is the leading cause of maternal deaths in the United Kingdom. That's why it's so critical that when we see women in our clinics with cardiac disease, we